everybody for the opportunity to come here and speak at the synagogue.
Could you tell me where this?
Just so you know how I fit in, I work with Catherine's husband at different times, and I was laughing as I was coming over here because I'm an Irish Catholic guy, but I did go in Fiddler on the Roof with her husband. I was in the play, so it was kind of a fun exchange that we had. We became friends through that. And then I met Catherine. She talked to me about the presentation. For those of you who don't know me actually, but I'm kind of tend to be a very interactive speaker, and just to tell you a little bit of my background is I actually was in industrial engineering before, so I tend to kind of think about things from kind of that 30,000 foot view and then gradually work down to the specifics. So as we're talking tonight, I thought it might be nice for just 15 minutes or so to really kind of give you this kind of 30,000 foot view of care near the end of life.
I'm sorry.
And what it is here, and what the issues are that we're talking about. And then as we move along, kind of begin to work into the specific questions. And I think when you hear this, you'll start to get an idea how your family member or your issues kind of fit into that, I hope. Like I said, I tend to be kind of a very open speaker, so if there's something that doesn't make sense, something you disagree with, something you want to challenge, no problem. Okay, so I always say, when I always talk to medical students when we talk about palliative care, one of the things I find is that when you spend enough time in it, that you often kind of start to wake up and look around and start to realize what's happening in the healthcare system, what's happening with patient care. And there's an old saying that when the Buddha was walking down the road, somebody said, "Who are you?" And he goes, "I am awake." And so I think when you start to kind of look at things in a different way, things start to make sense.
Maybe I can't try the irrigation.
So just a quick question for you. So anybody recognize this family? About 1915? No? No takers? Okay, this is the Vanston family from 1915. This is my great-grandfather. That's my great-grandmother. You can tell she's tired because she has 10 kids in the picture, and that's actually my grandfather. And I think the question I would pose to you is this. About 100 years ago, similar in Philadelphia, but also this is Northeast Pennsylvania, Scranton, Pennsylvania, where I hail from. A couple quick questions for you. So what was the average life expectancy you think that people passed away back then?
50.
48. And what were the top things that took people's lives?
Influenza or things like that.
Infection. Tuberculosis, influenza. My father was a funeral director, so my job when I turned 16 was to work in the Cathedral Cemetery in Scranton. There was a section called the flu, the 1918 flu. And so there was, many people were buried at that time. So infection, what else do we think was the cause?
Childbirth.
Childbirth. Okay, we don't think of that today. If somebody dies in childbirth, it's a catastrophe, right? Unheard of. Back then, it was the top three. One of the top three. And how about the last one?
Industrial accident.
Trauma. Okay, so any accident would occur and people would die. Yeah, let me pose another question to you. From the time you were diagnosed with the disease that took your life until the time you died, what was it measured in terms of time?
Days.
Months, rarely. Days or weeks or hours. My grandmother would talk about she was in the kind of the plague and Spanish lady in the influenza in 1918. And people would go to work in the morning and they would die that night. Okay? Unheard of. It was not part of our psyche, but that's the way things were. And how about the cost? Huge or less?
Less.
Yeah, very private, small, modest. Okay, people died at home. They were cared for at kind of the local hospital, if there was one. And here. So this was 100 years ago, roughly. Now we'll fast forward, and this is the Vanston family around 2005 or so. Okay, see there's less gray hair and a little bit more comfortable. But see, much smaller. And there's my father, my mother, and my sister, who's a little bit older than me. And so, average life expectancy today? About 78, okay, roughly. And What are the top causes of dying today? Cardiovascular
Stroke.
disease, stroke with dementia. What else?
Malignant.
And malignancies. So the top three. And from the time you're diagnosed from the disease that is going to take your life until you die, what is that measured in?
Years.
Years. Okay. And cost? Off the wall. Okay, off the wall cost. Okay. And the reason why I bring this up, just to give you kind of how this fits in too, my mom passed away about 3 years ago from metastatic cancer that came on relatively suddenly. My father had a hemorrhagic stroke about 3 years ago, around the same time. It was a bad couple months, and survived, and then became kind of demented and is now in kind of a long-term care facility here in New Jersey, and had a second stroke recently. So kind of more of a different kind of course. So if you look at this, okay, and like I said, I'm trying to kind of give you kind of the big picture from above and move down to specifics. If you think about this, no society, no civilization has ever faced this before. Okay, so this kind of explains why there's so much argument and chaos and uncertainty as to how to deal with it, because no other society or civilization has ever had individuals live this long. And even if you look at third world countries today, they're more like this. Right? So we've had the benefit of good public health and healthcare systems to get us to this point, and now we don't know what to do. Right? And that's the reality. So now we're stuck because we haven't really dealt with it, and we don't know as a society how to deal with it. Make sense?
Mm-hmm.
Okay. So I think that's always worthwhile doing this. So I want you for a minute just to step back and think about the whole population of the United States and think about what it looks like in a pie chart. And because you'll start to see how this fits together. But most of us took kind of a spot check in the United States. Most of us fit into this category, right? We're healthy, no particular problems or issues, right? We go to doctors when we have a cough or cold, or if we sprain our ankle or have a fracture or wrist, but generally healthy. We don't really need a whole lot of support from the healthcare system or doctors. Then when you start getting up around my age, you may have some coronary disease or diabetes or hypertension or a little bit of emphysema or specific problems. And these individuals, they use the healthcare system for the management of those problems. And occasionally they may have an exacerbation of problems. You have some emphysema and you get a cold or pneumonia and you're treated. So these people have chronic illness, but not life-changing, and they need a kind of acute preventive care. What we're talking about when we talk about end-of-life care in the United States is we talk about this group of chronically progressive, eventually fatal. These are the people who are moving into this trajectory at the end of life. And they need a variety of service and priorities, which we'll get into and we'll talk about. But usually 1 to 2% of those less than 65 and about 3 to 5% of those greater than 65. And as you get older, obviously, the number increases. So really, when we talk about end-of-life care, we're talking about that group. And so how does that kind of fit in? Well, I think the best way to think about it is kind of what Joanne Lynn, who's the author of the sports study, talked about, is kind of trajectories of disease. And if we think about how people progress over time with the disease near the end of life, we're able to kind of start to think about it conceptually in kind of a more objective, rational way. So let's just talk a little bit about that. The other thing I'd tell you is that if you look at people who die on Medicare, and most of us live to be more than 65. People who die before 65 today, you consider, oh my God, they're so young, can't believe that happened, but really most of us do. If you look at this, cancer about 20%. If you do, and that usually occurs actually more towards the earlier phase. And then about a third of people die from heart and lung disease, so respiratory, if you would know this. So about a third dies from heart disease, emphysema, or what we call end organ failure. If you survive these things, you move into something that we call kind of frailty, progressive wear and tear. Right? And the way I kind of describe this sometimes, and what I'm hearing when I listen to the audience, is many people have individuals who have kind of blown past these things. and have kind of progressive frailty. And it's kind of like your car. The lights go, the windshield wipers don't work, the tires go, and kind of accumulated thing. And sometimes I use, it's like your great aunt Mary, who's got diabetes, hypertension, coronary disease, has some problems with the eyes, fell and broke their hip. These aren't quite as good, had a hip replacement 2 years ago, and kind of more of this progressive thing. And so many people, if they survive this, move into that category. Does this make sense?
Yeah.
Okay. So I think if you look at this kind of in terms of paradigm, is that some people have what's called a short period of decline before dying. This is the trajectory of someone with cancer. And we'll get into that. Others have this kind of limited reserve. Either their kidneys or their heart or their lungs are failing. So they'll have what they call kind of exacerbation remission. They just don't have the resilience that they had when they were younger. And then these people often will move into a period of frailty with or without dementia if they survive those first two. Kind of depressing. I feel like I'm bringing everybody down. I think it's worthwhile at least kind of thinking about this. The reality is that most of us, if we live long enough, will develop some chronic condition. That's just the nature of being human. Almost everyone experiences one of those kind of trajectories of disease that I've described. I'll get into more detail. Once you start on that pathway, chances are you're not going to jump off of that. Once you move into frailty, chances are you're not going to bounce out of frailty. And a transition, like I said, from limited reserve. Sometimes people have COPD or congestive heart failure, then they start losing their nutrition, they start getting weaker, a little bit of dementia, increasing frailty, and they kind of move into that period. And so that's common. So I'm going to kind of try to pull you in kind of discussion just to kind of begin to think about this, because I think that there's more wisdom in the room here than I have myself. But if you think about cancer, this is a trajectory disease. This is what's called function over time. And I'll tell you that people who have cancer generally do very well for a significant period of time. And at a certain point, however, they start to lose function. They start to slide. And that often occurs in the last 3-4 months of life, where the person suddenly starts coming to the hospital, they're not able to care for themselves, they need more support, and oftentimes they die within that period of time. They have symptom burden during treatment, but the escalation of symptoms occur oftentimes in this last phase. Generally, when they're along this phase, generally fairly can be controlled and managed. So this is the model of end-of-life care that we have in our psyche as a society. So you guys are kind of around my age or older. Remember Love Story?
Yes.
Okay, remember Terms of Endearment? I say this to medical resident students, they just look at me like I'm from another planet, right? But in those movies, what happens? The person gets diagnosed with some kind of malignancy, they come home, they resolve all their issues, they die peacefully, and it's all nice, right? And this is kind of what's in our mind as a society. Because this will be important when we think about how we think about this as a society as we move on. So what do these people need? When you think about it near the end of life, what are the things that they require? Support. What kind of support?
Situation.
Mm-hmm.
Their family.
They need love.
They need love. So they need that family, psychosocial, that support and love. They need that spiritual support. They need good pain management. They need good symptom management. They need not to be short of breath, not be in pain, not to be anxious, not to be depressed. And those are the kind of things that these people need. And they need a network of support around them. And this is the model of hospice care. This is where hospice care developed. This is really where hospice care grew out of, and so effective. So that's the kind of symptom they need. And I'm kind of moving quickly because I don't want to take up all the time, but these people need supportive services throughout the course of the illness. You're diagnosed with cancer, you're going to need support from the beginning of some kind. But including concurrent palliative care, which is my field, and oncology care. So the oncologist and the palliative medicine doc work together. And they need advanced planning. okay, which Alan will get into and has like much more expertise than I do. But ultimately, hospice care. Yes.
I have one comment. Been doing this for about 16 years now, and with almost with no exception, no matter how intelligent the person is, I think people choose to be in denial, and almost always don't want to hear the word hospice. So I think maybe the wording has to be changed. And almost always they tell me, yes, you're right. We went on hospice too late. I wish I would have done it earlier, because there's so much they can get through Medicare as far as free help. And I think that people, and sometimes I don't argue. I happen to be a very flexible person. I'll just go with the flow. And I think that maybe our psyche, I came to believe, is such that a little bit of denial is maybe helping us
Well,
to survive.
I think so, absolutely. And I also think the other thing, and I think we should talk about this a little bit more, once we're done with this piece, but is to say that people who, there's this idea that hospice is somehow different. Oh, you've jumped over this leap and made this big decision in hospice. And my argument is that if I were king, I don't want this out to be in the public, but I think the whole concept of hospice as an entity should be go away. It should be based on what people need.
Yes.
And if you say, hey, listen, you have pain, you need more assistance with pain management. You need support at home. You need an advanced directive. What's so crazy about that? Right?
Well, I think people and even families look at it as if it was a death sentence. Okay,
That's
I
exactly
agreed
right.
to die.
That's exactly right.
And people have the tendency of holding on and fighting it.
Absolutely.
Fear
Absolutely.
of
So,
death, and
Absolutely.
the sense of
Yeah.
giving up,
rather than really, you just need more care.
or the
So-
relief of pain and
Yeah.
symptoms.
Yeah, right, exactly. So think about this. Now let's kind of fast forward a little bit. Let's think about the person who has emphysema, the patient who has heart failure. What does their trajectory look like? Much different than the cancer patient, right? These are the person who has exacerbation of their heart failure and then remission. Exacerbation, remission. Exacerbation, remission over time. And what happens to these individuals is they over time, they start to come into the hospital more frequently. Their intensity of their events is worse. And that death often occurs suddenly, which we'll get into more detail. So these individuals have a couple of things I'd point out. That incomplete recovery from each event. Okay, those of you who have experienced that with family members, when they do have an exacerbation, they don't come back at 100% frequently. That our ability to prognosticate, okay, doctors and patients and family members, we don't think of these diseases as ultimately fatal diseases, right? I've had patients who had an ejection fraction of like 1 on their heart. They'd be like, Doc, thank God I don't have cancer. Boy, you'd be lucky to have cancer with the way your heart is, you know?
I'm sorry.
And sure.
I'm sorry. Are you saying doctors think that
Oh,
this is not
absolutely.
doctors think that these diseases are not fatal?
Yes.
Or that
in
they
some
think
ways.
they're not fatal at the moment,
They think they're not fatal at the moment,
but they
I
know
mean-
they're fatal.
in a theoretical sense, but not for the patient right in front of them.
That's a big issue. That's a very big issue.
So, what do these people need?
I think in a way there is active treatment. There's active treatment.
But does it change the disease?
Exactly. There's no, there's something only they can do,
Right.
and that's my
Right. There's something they can do, but they're not actually changing the disease dramatically. So, what do you think these people need at the end of life? If you're thinking about this as a family member. The person who has heart failure, comfort, and they need. But the person who has heart failure, for example, you still need to watch their cardiac medications, right? You need to watch their volume. You want to avoid salt. You want to do things like that that are going to monitor their disease. So even though they're at the end of their life, they still need good monitoring of symptoms. This is not someone who'd like to stop everything for them. because they still need management of their underlying disease. And they often need kind of that ongoing support. This is something to think about with heart disease and COPD also, is that this was a study that was done by the support study that looked at doctors' estimate of surviving 6 months or more that was done in hospitals for patients who were hospitalized. And this was what the estimate was the day before they died. So in patients who had congestive heart failure or COPD, on the day before they died, doctors gave them a 50 or 60% chance of living 6 months. The day before they died. Okay. And that's been replicated. And what does that tell you? It tells you that we really don't know whether the patient has emphysema or COPD or kidney disease or liver disease when they're going to die. And the way Joanne Lynn speaks about it is that the week that these individuals die starts out like any other week. It's any different. So the reason why I bring that up is because we don't know who's going to die when. So these are individuals who need good advanced directives. I'm leading into that. These are the patients who need excellent planning because you're going to be caught flat-footed. Look okay, they're no different. Okay? And every medical resident you talk to will talk about the patient who looked perfect, they're going to send them home, and they arrest them. Now, so these individuals need ongoing disease management. I always go crazy. You'll appreciate this. Is that the home health program will send somebody home with heart failure and say, "Well, we'll see you 4 times and then we go away." How insane is that? They have a disease that's going to be with them for the rest of their life. They should be getting the support for the rest of their life. Management. Advanced planning. Hear this over and over. You need flexible services that if that person gets short of breath at 2 a.m, you can move services to the house and then bring it back. Okay, and increase services and move back. Okay, I fought with my hospital up in Scranton, Pennsylvania, to say, hey, listen, we have patients in hospice. We're able to keep them out of the hospital, and they showed me the door because they were making money on the people coming in the hospital. They were not interested in keeping them out of the hospital. So something to kind of think about. Now,
Has that changed now?
it's going to, I
You
think,
hear
because
about, keeping the patients out of the hospital
Right.
makes the hospital
financial
not
now,
lose money.
exactly.
Not necessarily making money, but
Exactly.
not losing
But
money.
the incentive is still to do more procedures, doing more interventions. There's still that. But I think that's going to change. Now, for many of you in the audience, this is kind of that frailty. And the way to think about this is these individuals have the fragility of multiple body systems, right? That they have substantial risks from all kinds of things in the environment, right? The flu can come along, they can fall and break their hip, they can have, some urinary tract infection, they can slip at night, they may not see something, kind of this risk throughout the environment to them. And that aggressive treatment of one illness, if you try to fix one problem, another one comes to the forefront. Okay? And so the way to think about this is a great picture. This is the guy. Remember this guy who went across the World Trade Center?
Yes, amazing.
We think about these individual fragility as if they're walking on a tightrope. And at some point, walking along that tightrope, something's going to intersect and knock them off. Start a cascade of problems. It may be falling, breaking it. It may be a congestive heart failure. It may be a small heart attack. It may be a urinary tract infection. And then they go into the hospital and it's cascade. Some of you may have experienced that. It's a cascade of problems that progress. The problem is not the individual disease that occurs near the end of life. Sometimes hospitals die like, if we just put on an ACE inhibitor, if we just put on a beta blocker, we just give them this medication, everything will be fine. The reality is the real problem is that they're on the tightrope to begin with, and that's what's the problem. So, and I'll throw this out just to rattle everybody's cage. Now, if you saw this in the paper, new drug cures coronary artery disease in the elderly, what would you think? Fantastic, right? Sexy, powerful. Okay, great. That you get in the front of it.
What happens next?
Well, that's exactly right, because that's the equivalent of saying new drug increases the incidence of cancer, frailty, and dementia. You fix one problem, and another one replaces it. And there's an interesting study. I got everybody at Cooper all upset with me because they said, well, what if you cured cancer today in the United States? This study that was done in 1972 had no impact on life expectancy at all. Right? So we talk about curing cancer and disease and how great that is and wonderful. If we do that, then we die of other things. Because all these things happen near the end of life.
You're gonna die of something.
we're kind of hardwired to live into about 78 or so, and if we fix one problem, another problem will come, and basically we'll check out around 78 or so in general. And this is actually from the CDC. You'll notice they said all causes, heart disease, you'll notice has gone down, emphysema has gone down, frailty, Alzheimer's disease has increased. So we see more.
Why is that?
Well, because if you fix one problem, then they have to live, they're going to develop another.
Why so many people have dementia and Alzheimer's? Is it environmental? Is it hardening of the arteries? It's like
I don't know. But there's a quote from the Grateful Dead: "If the thunder don't get you, the lightning will." So, what do these people need? And I think that for those of you in the audience who are talking about this, I think that supportive services. I think more than any other disease, the care of persons with frailty is really caregiver issues. It is difficult to. It requires a great deal of time, family support, and energy to care for somebody who has frailty or dementia. That there needs to be support for caregivers. In addition, we need to develop quality long-term care facilities. There are some good ones, but I think all of us have a history of being exposed to bad ones. And then advanced planning. Okay, being prepared for that wind that's going to knock them off the tightrope. And I think specialized hospice care that's actually so I'm going to try to move along quickly, but if you just think about this as a country, 1960, 0.5% of the population, 1 million, was greater than 85. 2.5, okay, by 2030, 15 years. Greater than 65, 9% of the population, 22% of the population by 2030. So we're facing this wave of issues in regard to healthcare. And I think as a society we have to start wrestling with it, and as a medical society. So I'll stop there. I went longer than I thought I should have, but and then I think it might be a great opportunity to talk. Okay.
Thanks, Jay.
Sure.